Hello, welcome to Behavioral Health 107, Mental Health Disorders. Today we're going to be discussing eating disorders. So, what are eating disorders? They are illnesses that are characterized by irregular eating habits and severe distress or concern about body weight or shape. Eating disorders can develop during any stage in life, but typically appear during the teen years or young adulthood. Eating disorders commonly coexist with other conditions such as anxiety disorders, substance abuse, or depression. What causes eating disorders? It is generally believed that a combination of biological, psychological, and/or environmental abnormalities contribute to the development of these illnesses. Examples of biological factors include irregular hormone functions, genetics. The tie between eating disorders and one's genes is still being heavily researched, but we know that genetics is part of the story. Nutritional deficiencies. Examples of psychological factors include negative body image and poor self-esteem. In terms of environmental factors, things that contribute include dysfunctional family dynamics, professions and careers that promote being thin and weight loss, such as ballet and modeling, aesthetically oriented sports where an emphasis is placed on maintaining a lean body for enhanced performance. Examples include rowing, diving, ballet, gymnastics, wrestling, and long-distance running. Family and childhood traumas, including childhood sexual abuse and severe trauma. Cultural and/or peer pressure among friends and coworkers, and stressful life changes or transitions. We're going to be looking at these disorders, which are listed in the DSM-5. Anorexia nervosa, Bulimia nervosa, binge eating disorder, Pica, rumination, avoidant or restrictive food intake disorder. Anorexia nervosa is an eating disorder characterized by self-induced starvation and excessive weight loss. According to the National Institute of Mental Health, research tells us that anorexia is a brain disease with severe metabolic effects on the entire body. Anorexia is the third most common chronic illness among adolescents. The diagnostic criteria based on the DSM-5 includes, number 1, restriction of calories compared to healthy requirements. This leads to significantly lower body weight in the context of age, sex, developmental trajectory, and physical health. Number 2, intense fear of gaining weight or becoming fat, even though they are underweight. Number 3, disturbance in the way in which one's body weight or shape is perceived, undue influence of body weight or shape on self-evaluation, or denial of the seriousness of the current low body weight. Symptoms associated with anorexia nervosa include significant weight loss, distorted body image, intense fear and anxiety about gaining weight, preoccupation with weight, calories, food, etc., feelings of guilt after eating, denial of low weight, high levels of anxiety and/or depression, abuse of laxatives, diet pills, or diuretics, excessive and compulsive exercise, low self-esteem, self-injury, withdrawal from friends and activities, excuses for not eating or denial of hunger, food rituals that are intense, dramatic mood swings, pale appearance, yellowish skin tone, thin, dull, and dry hair, skin, and nails, intolerance to cold or hypothermia, and fatigue or fainting spells. Health complications can include amenorrhea, which is the cessation of the menstrual cycle in girls, abnormally slow and or irregular heartbeat, low blood pressure, anemia, poor circulation in hands and feet, muscle loss and weakness, including the heart, dehydration and kidney failure, edema or swelling, memory loss and disorientation, chronic constipation, growth of lanugo hair, which is the hair usually
incident
found
rates
on
for
infants
anorexia
nervosa
very
are
highest
fine baby
for females
hair that covers
aged
their
15
bodies when they're
through 19 years of age,
just
they
born,
constitute
and
approximately
bone density
40% of
loss
all
or
identified
osteoporosis.
cases.
This disease is primarily one seen only in Western countries, primarily North America and European countries. And the reason for that is if you go to India or China, where food is not necessarily plentiful, you're not going to see people refusing food. Generally, this is a disease that affects people where food is plentiful. The incidence rate among females is 4.7 per 100,000 persons per year. The incident rate among males is below 1 per 100,000 persons per year. In a study from Scotland, 23 of 524 patients, or 4.4%, with anorexia nervosa died. The median length of time between diagnosis and death was 11 years. This is an extremely high number considering that most of the patients are fairly young. The treatments that are available for anorexia nervosa include family-based treatment, which is the most popular form of treatment. In anorexics with severe symptoms, family-based treatment has been shown to be more effective than individual therapy because it focuses on the family dynamics of the household. Usually, the reason that someone is going through anorexia has something to do with the dynamics involved in the family. And if the family's behavior does not change, the anorexic's behavior and thought patterns also may not change. The motivation to change has a significant effect on the success of anorexia nervosa therapy, and it is especially helpful for girls. Because of the high rate of relapse, enhanced cognitive behavioral therapy, or CBT-E, is a therapeutic option developed especially for treating eating disorders. CBT-E sets realistic expectations, identifies potential setbacks, develops strategies to allow the patient to respond to setbacks, focuses on how to maintain progress and develop strategies for relapses. Bulimia nervosa is an eating disorder characterized as binging, which is the excessive or compulsive consumption of food, and purging, which basically means getting rid of that food. The symptoms include binging and purging, eating beyond the point of fullness, feeling out of control while you're eating, the inappropriate compensatory behaviors following a binge, meaning the vomiting, the overuse of laxatives, the ways that people will purge the food to get it out of their body, frequent dieting, and extreme concern with body weight and shape. The DSM-5 diagnostic criteria for bulimia nervosa include recurrent episodes of binge eating characterized by both of the following. Number 1, eating in a discrete amount of time, within a 2-hour period, large amounts of food. And number 2, a sense of lack of control over eating during an episode. Recurrent inappropriate behavior in order to prevent weight gain, i.e. purging. The binge eating and behaviors both occur on average at least once a week for 3 months. Self-evaluation is unduly influenced by body shape and weight, and the disturbance does not occur exclusively during episodes of anorexia nervosa. The symptoms of bulimia include binging and purging, secretive eating and or missing food, visits to the bathroom after meals, and a lot of people will go to the restroom after they eat, but this becomes an ongoing process and the person is gone for 10-15 minutes. Preoccupation with food, their weight fluctuates, they may engage in self-harm or self-injury. They have an excessive or compulsive exercise regime despite fatigue, illness, or injury. They abuse laxatives, diet pills, and or diuretics. They have a high level of anxiety and or depression. They have swollen parotid glands in their cheeks and necks from the need to vomit, and that swells up the glands. Discoloration and or staining of the teeth. Broken blood vessels in the eyes and or face. When you are vomiting, it takes a lot of pressure and it will, in fact, break the blood vessels in your eyes, as if someone has tried to choke you. Calluses on the back of the hands and knuckles from self-induced vomiting. The first time you force yourself to vomit, you don't have to really gag yourself too hard. But if you're doing it 2 or 3 times a day, you're going to have to go deeper and deeper, and it becomes a very dangerous situation. Sore throat, heartburn and reflux, feelings of shame and guilt, and criticism and low self-esteem. Health complications may include electrolyte imbalances that can lead to irregular heartbeat and seizures, edema or swelling, dehydration, vitamin and mineral deficiencies, gastrointestinal problems, chronic irregular bowel movements and constipation, inflammation and possible rupture of the esophagus, tears in the lining of the stomach, chronic kidney problems or kidney failure, and ultimately tooth decay. And this is an example of what happens after a extensive amount of purging. The incidence is approximately 6.6 per 100,000 persons in 2000. However, it is acknowledged that only a very small minority of the patients with bulimia nervosa enter the mental health care system, so the incidence is definitely underreported. Lifetime prevalence is estimated to be about 2%, and it is primarily females who seek medical help. Bulimic symptoms often have a later onset than anorexic symptoms, so the prevalence of bulimia is generally lower among adolescent women than among young adult women. And the lifetime prevalence for males is 0.5%, so much lower in men, but still a fairly significant number. Treatment for bulimia nervosa includes weeks or months before any significant results may occur. Antidepressants such as Prozac and antipsychotics can be effective treatments. Psychotherapy is generally regarded as being a more effective means to treat bulimia nervosa than medication. Cognitive behavioral therapy emphasizes the need to correct detrimental behaviors through the use of strategies and actions structured around specific behaviors. A combination of medication. Next, we're going to move on to binge eating disorder. This disorder. An episode of binge eating is characterized by both of the following: eating in a specific amount of time, so for example with any 2-hour period, an amount of food that is definitely larger than most people would eat in a similar period of time under similar circumstances. And secondly, a feeling not having control over eating during the episode. For example, a feeling that one cannot stop eating or control what or how much one is eating. The diagnostic criteria for binge eating disorder is associated with 3 or more of the following: Number 1, eating much more rapidly than normal. Number 2, eating until feeling uncomfortably full. Number 3, eating large amounts of food when not feeling physically hungry. Number 4, eating alone because of feeling embarrassed by how much one is eating. And number 5, feeling disgusted with oneself, depressed, or very guilty afterwards. There is a marked distress regarding binge eating is present, and the binge eating occurs on average at least once a week for 3 months. Some of the additional symptoms include, as I've said before, eating large quantities of food without purging behavior when not hungry, the lack of control, eating until uncomfortably or painfully full, weight gain or weight fluctuations, feelings of shame and guilt, self-medicating with food. So in the same way that people will often self-medicate with alcohol or drugs, there are people who self-medicate with food. It makes them feel better. They get a sense of comfort from eating. Eating alone or secretive eating, hiding food, high levels of anxiety and or depression, and low self-esteem. Health complications can include being overweight or obese, type 2 diabetes, osteoarthritis, lipid abnormalities, increased cholesterol in other words, increased blood pressure, chronic kidney problems, gastrointestinal problems, heart disease, gallbladder disease, joint and muscle pain, and sleep apnea. The prevalence is pretty high. It is the most common eating disorder in the United States. An estimated 3.5% of women and 2% of men. 1.6% are adolescents. It is most common in women in early adulthood, but it becomes more common in men when they hit midlife. The treatment for binge eating disorder is usually psychotherapy, and there are multiple psychology-based therapies that have been found to be effective, especially combined with one another. Dialectical behavioral therapy includes, it presumes that there are people who have sudden and intense responses to stimuli that go beyond the usual response. Dialectical behavior therapy helps patients develop coping skills to manage their response. Behavioral weight loss helps patients develop realistic weight loss and eating control goals through their weight loss process. Cognitive behavioral therapy, which we've talked about extensively through this course, and interpersonal psychotherapy, which helps the patient uncover the psychosocial root causes of binge eating while identifying why patients turn to this behavior as a coping mechanism. The current perspective is that a combination of psychotherapy and medications can be most effective in curbing binge eating disorder. These medications can include anticonvulsants, antidepressants, and anti-obesity medication. The reason that we use anticonvulsants is because they suppress the appetite, which will reduce the biological urge to eat. A nutritionist can work with the client on proper meal proportions and planning to ensure that the client will not resort to binging behaviors. Okay, now we're going to move on to something that you may have seen on TV. There's a show called My Strange Addiction, and this is called Pica. Pica is a pattern of eating non-food material such as dirt, sand, or paper. Pica is normal in young children. Between 10 and 32% of children ages 1 to 6 have these behaviors. It is considered age appropriate. Pica also occurs during pregnancy. Sometimes a lack of certain nutrients, such as zinc deficiency, can trigger the unusual cravings. So a pregnant woman oftentimes craves dirt or sand because she has a deficiency that is based in a particular mineral. Pica may also occur in adults who crave a certain texture in their mouth. Adults with developmental disabilities will often engage in these behaviors as well. The diagnostic criteria for pica includes being a persistent eating of non-nutritious, non-food substances for a period of at least 1 month. The eating of non-nutritious, non-food substances is inappropriate to the developmental age of the individual, over age 5. So if there's an adult or someone in their late teens, this is a diagnostic issue. This is not age appropriate. The eating behavior is not part of a culturally supported or socially normative practice, which is particularly popular in Nigeria and Zambia as part of spiritual rituals. And in these spiritual rituals, they may eat certain items like small rocks or pieces of wood that will bring them closer to their ancestors. Pica is sometimes linked to obsessive compulsive disorder and impulse disorder because of the persistent eating of non-food items. Like those with OCD, individuals with pica are conscious of their behavior, even though it is unhealthy and illogical behavior, and consequently will hide their activities out of a feeling of shame. Symptoms of pica are similar to what you would see in a malnourished anorexic. They have a mineral deficiency, they have unhealthy nails and hair, they have dental issues, and they are usually experiencing weight loss. Individuals feigning a disorder may ingest non-food items in order to imitate the symptoms of a more serious disorder. And we looked at this when we looked at factitious disorders or Munchausen disorder. Some of the health complications of pica include Bezor, which is a mass of indigestible material trapped inside the body, usually in the stomach. And the picture I have here is one of the most famous cases of pica. In 1929, a patient suffering from pica was found to have 1,446 total non-food items in his stomach. And they included 453 nails, 148 seeds, 115 hairpins, 85 small stones, 63 buttons, and 42 screws. No chewing gum, so that story about chewing gum staying inside you for 7 years is not actually true. The point being is that, we have this idea that, eating one thing will be a bad situation. These people will eat many, many, many items, and it'll cause them very serious health complications, including infections, intestinal blockages, lead poisoning, malnutrition, abdominal pain, colon obstruction, and of course damaged teeth. If the pica is not related to a need for nutrients, studies have shown it can be a potential consequence of injury due to the hippocampal area in the brain. Pica is also a way to relieve anxiety for some people who experience anxiety disorders, which again is similar to OCD. The Handbook of Clinical Child Psychology currently estimates that the prevalence rates of pica range from 4 to 26% among developmentally disabled populations. Research among non-disabled populations takes the form of individual case studies, making prevalence rates difficult to estimate. It is not something that people really want to go to the doctor unless they're very, very sick. Again, most people feel a lot of shame and they know it's wrong, so they hide it as much as they can. When we're treating pica, first the doctor will assess the patient's nutrient levels and check for other medical conditions such as lead poisoning. Behavioral therapy uses conditioning, which connects the pica behavior with negative consequences or punishment, mild aversion therapy. Then the person gets rewarded for eating normal foods. People who have developmental disorders are prescribed medications to help inhibit the patient's craving. So somebody who has an IQ of 60 or 55 may not understand that they can't eat chalk or rocks, and medication has to be utilized in order to help that particular person understand or help them not eat that stuff. Moving on, we have rumination, which is an eating disorder characterized by the regurgitation of undigested food. It is different from other eating disorders such as anorexia nervosa because it is involuntary. Regurgitation is not used as a means of losing or otherwise controlling weight. Rumination disorder also does not involve indigestion, nausea, vomiting, or related feelings of disgust or discomfort. Individuals use coughing, tongue movements, or abdominal tongue contractions to bring food to the mouth. Young infants often arch their backs and make sucking movements with their tongue to stimulate regurgitation. The diagnostic criteria requires repeated regurgitation of food that persists for at least 1 month. Adults typically spit out the regurgitated food, but infants, young children, and adults with developmental disabilities may re-chew and swallow the food. Rumination typically occurs for 1 to 2 hours after completing a meal and typically happens after every meal. The DSM-5 explains that diagnosis of rumination disorder requires that the regurgitation may not be related to any gastrointestinal disorder and may not be exclusively related to an eating disorder intended to control weight. The onset of symptoms can occur any time during the lifespan, although in infants, symptoms usually present between 3 and 12 months. Health implications of rumination include dehydration, malnutrition, esophageal damage, dental complications, and bad breath. In infants and young children diagnosed with rumination disorder, weight loss or failure to gain weight is common, as well as growth and learning delays. Many patients find pleasure in the habitual regurgitating behavior related to rumination disorder. Some describe it as soothing or a coping strategy for dealing with anxiety. Still, many patients are aware that the behavior is socially unacceptable and try to hide it. The prevalence is unknown because it is often hidden by people who engage in this behavior. The prevalence in developmentally disabled adults is between 6 and 10%. Treatment includes behavioral therapy, specifically called diaphragmatic breathing. It is learned by placing one hand on the chest and the other hand on the abdomen. The patient is then instructed that the hand placed on the abdomen may only move as the result of breathing, which relaxes the diaphragm during and after eating. Chewing gum after meals has also been shown to be very effective. There are no pharmaceutical or surgical interventions that are effective. Finally, we're going to talk about avoidant or restrictive food intake disorder. This condition involves rigidity around eating by avoiding certain types of food, resulting in insufficient caloric intake. This is beyond being a picky eater or avoiding foods for adaptive and prudent reasons. For example, if you have a nut allergy or if you're lactose intolerant. It is very common in children under the age of 10. Prevalence is around 25%, but usually disappears as the child enters puberty. The symptoms can result from traumatic avoidance related to food, such as choking or painful esophageal spasms, refusal to eat foods based on smell, taste, texture, or appearance, or concern about aversive consequences of eating, There is a persistent failure to meet nutritional or caloric needs, which result in significant weight loss and inability to gain weight, and will avoid a certain type of food, for example gluten, despite there not being a scientific or medical reason to avoid it. Now, there are absolutely some people who are allergic to gluten or have a gluten sensitivity, but it is a rare issue. Most people do not have this sensitivity, but they believe that they do. The treatment includes cognitive behavioral therapy, which challenges rigid beliefs about food and the fear of choking. Psychoeducational information from the scientific literature on nutrition may help if food avoidance is based on inaccurate information. However, keep in mind, some people refuse to accept science as a valid reason. So, there is a fairly large proportion of people who do not trust science and believe that it is a conspiracy, and as such, we keep in mind that these percentage of the population will not be convinced no matter how much scientific evidence proves them wrong or can demonstrate anything that will go against what they truly believe. All right, here are the works cited. If you have any questions, please feel free to email or text me or leave a comment, and I hope you have a fabulous day. Thank you very much.